Imagine that you or your dad is diagnosed with Parkinson's disease, and you ask yourself when this doctor is going to order a brain MRI. How come this doctor is just evaluating my dad for 10 minutes and he's able to tell that he has Parkinson's disease? How come? No blood test, no MRI, no DAT scan, just observing. How come? I will tell you why. My name is Dr. Sayas. I'm a movement disorder specialist. The main reason is because still Parkinson's disease is a clinical diagnosis still in November 2024. And now, actually currently during this year, there is a lot of controversy about new definitions. I'm talking about biological definition. So this is a very hot topic now in our field because there are multiple biomarkers available during the last few years. For example, I'm talking about genetic testing, skin biopsy, uh, spinal fluid evaluation, looking for the abnormal protein that you see or you typically see in people with Parkinson's disease. There's also sophisticated imaging study technology, such as DAT scans that prove objectively that there is a deficiency of dopamine in the brain. For now, do not worry about those biomarkers or biological definitions and those controversies, because still the diagnosis of Parkinson's disease in November 2024 is clinical. A clear indication to get a brain MRI when you have a patient with Parkinsonism is when you find atypical features. So atypical characteristic. Parkinson's disease is typical. When you find something that doesn't make sense, that is not typical, and I will tell you what that soon, this is when you order an MRI of the brain. Now, let's go over the criteria. So this is the criteria that you see the publication here in on the screen. This was published 9 years ago, 2015. Okay, and this is what still we have. So we follow this criteria to make the diagnosis, the clinical diagnosis of Parkinson's disease. Based on this criteria, the most important thing, the first step is to make the diagnosis to be sure, basically, that you have Parkinsonism. And when I say Parkinsonism, I'm not saying that you have Parkinson's disease. Parkinsonism is the big term, okay? So Parkinsonism in the setting of Parkinson's disease means that, number one, that's the first step, is you need to have bradykinesia. What is that? Bradykinesia means a slow movement, but not just slow. You need to have decrement in the amplitude and or speed of the movement, of the repetitive movement. For example, tapping of the fingers. So you need to have bradykinesia. That's the first step. And then you need to have either stiffness, which is rigidity, stiffness, or resting tremor, either or. Now, many patients, they have both. That's the first step. So when you see that, then you can say patient has Parkinsonism. Now, remember, the most common cause of Parkinsonism is Parkinson's disease, by far. But there are many conditions that can give you Parkinsonism, including medications. So if I block dopamine receptors with a medication, and you are one of those patients susceptible to have drug-induced Parkinsonism, you will look like a patient with Parkinson's disease, but you don't have Parkinson's disease. Because if I stop those medications and I see you in 3-6 months, you will be normal. Okay, now there is a question why those patients are susceptible. That's another topic. This is because they will have Parkinson's disease at some point later in life? I don't know. Nobody knows. So going back to the criteria, there are important things that you need to look. And if you see absolute, this is the absolute exclusion criteria that you will see this in the screen. If you see this, this is not Parkinson's disease. Basically, you are ruling out Parkinson's disease when you see one of these 9 absolute exclusion criteria. Okay? So let me repeat that again. Once you diagnose, once you identify Parkinsonism, then you look for absolute exclusionary criteria. There are 9, okay? And we'll mention all of them. Number 1, if you have cerebellar is the back of the head. This we call that sometimes the small brain. So if you have cerebellar findings, so those patients, they have incoordination, so they cannot coordinate the movement well. So they have eye movement abnormalities. Scanning speech. Scanning speech is like you talk and you sound like being drunk. This is how the books and experts describe scanning speech, typically seen in patients with cerebellar dysfunction. So when you see that this type of voice, which is different from the typical voice that you see in people with Parkinson, this is not Parkinson's disease. This is something else related with the cerebellum. There could be even multiple system atrophy, which is MSA, which is a different condition. And many other things might affect the cerebellum. That's number 1. Number 2, if you cannot look down, this is not Parkinson's disease. This is something else. So Parkinson's disease should not affect your vertical eye movements. Okay, you see that in patients with another conditions. So this is very atypical. That's number 2. Number 3, if you have criteria for behavioral frontotemporal dementia, or you have significant severe language problems characteristic for something that we call primary progressive aphasia, this is not Parkinson's disease. This is something else, right? Number 4, if you have Parkinsonism just located on the lower extremity, in the lower extremities, for more than 3 years, look for something else. This is not Parkinson's disease. It's probably vascular Parkinsonism, which is a controversial topic as well, or normal pressure hydrocephalus, okay, which is a different condition, very rare as well, and controversial as well, okay? So I'm telling you that if you have any of these 9 issues, look for something else, because you probably don't have Parkinson's disease. These actually exclude the diagnosis of Parkinson's disease based on these criteria. So we discussed about 4. Let's go to number 5. If you are getting a medication that blocks dopamine, I cannot make the diagnosis of Parkinson's disease either, because when you take those medications, there are many that can block dopamine receptors, especially D2. You will look like a patient with Parkinson's disease, but you don't have Parkinson's disease. You have medication-induced Parkinsonism, okay? That's number 5. Number 6, if you are taking at least 600 milligrams of levodopa, so 600 milligrams of levodopa means that you take the 25/100 milligrams Cinemet, carbidopa levodopa tablet, 2-3 times a day, that means that you take 600 milligrams, right? Total dose per day. So if you take this amount of levodopa and there is no significant improvement in your bradykinesia, in your mobility or rigidity, then most likely you don't have Parkinson's disease. And actually, if you have that, that technically rule out the diagnosis of Parkinson's disease. Look for something else, other condition related with Parkinsonism. That's number 6. Number 7, if you have unexplained, we cannot explain that you have cortical sensory disturbance. What is that? If I put you something in your hand and you cannot, with the eyes closed, and you cannot identify what I'm putting you on your hand, that's not Parkinson's disease. This is something else. Maybe you have a stroke, or you have something that we call cortical basal syndrome or degeneration. Okay? Number 9, if you have a normal DAT scan, DAT scan. This is a nuclear medicine test. I have a video explaining what is a DAT scan and when to order a DAT scan. So if you have a normal DAT scan, that rule out Parkinson's disease. Number 9, and this is the one that I don't like this one because it's very, very vague and I think should be eliminated. So this basically indicate that if an expert think that you have something else not related with Parkinson's disease, it's not Parkinson's disease. So it's not too specific, and the question here, what they mean with expert, right? So I'm assuming that expert would be a movement disorder neurologist. So that doesn't help too much, but it's okay. That's the number 9. Again, if you have any of these 9 points described above, which I'm talking about the absolute exclusion criteria, then you do not have Parkinson's disease and you really need an MRI of the brain. Okay? You need to rule out other causes. Okay? You need to rule out other causes, at least now in 2024 November, right? The exception for this is a patient who is taking antidopaminergic, so which means a medication that blocks dopamine and develop Parkinsonism. So you still cannot make the diagnosis of Parkinson's disease, but this patient can have Parkinson's disease. So those patients, they actually don't need an MRI, they need that DAT scan. So the DAT scan easily can differentiate between a patient with primary Parkinsonism, well, we call that idiopathic Parkinson's disease or Parkinson's disease, versus a drug-induced Parkinsonism. So you have 2 options, or you do a DAT scan, or if the patient can stop the medication that you think is causing Parkinsonism, then you tell the patient to taper down the medication, and then you reevaluate in 3 to 6 months to see what happened. So remember that those medications cannot stop cold turkey. And if you are taking those medications for depression or schizophrenia, you need to talk with your psychiatrist. So you cannot do this by yourself. Okay? Remember, very important, mental health is more important, in my opinion, than having tremors and slow movements. So that's why it's extremely important that we have some type of communication with other providers when we are dealing with patients with Parkinsonism, specifically in patients that we are suspecting drug-induced Parkinsonism. The next step is to evaluate for supportive criteria for Parkinson's disease, PD criteria. You need to have at least 2 of these 4 that I'm going to tell you right now. At least 2 of these 4. Number 1, you need to have a dramatic response to levodopa. When I say dramatic response to levodopa, it's not like you say, maybe I'm not sure if it's helping me or not sure. So you need to have a dramatic. So patients can tell that the levodopa helped them significantly. So we actually have a score, a number that you get every time that you come to the movement disorder clinic. So we call that the UPDRS score. And typically when you have a patient with Parkinson's disease, you have an improvement of at least 30%, assuming that you are taking the correct dose, which means enough levodopa. We'll talk about that soon. The only exception to this rule is tremors, because sometimes you still can have Parkinson's disease and you think that the medication is not doing anything for you because you are evaluating the effectiveness of the medication based on your tremors. That's not the best way. This is one of the reasons why some patients tell the doctor, I don't know, but this medication is not doing anything for me. But when you ask them, what do you mean with that? My tremors are the same. Because frequently you have patients in the clinic that the medication, the levodopa, even a higher dose, don't touch the tremor. And those patients usually end up having deep brain stimulation because the deep brain stimulation is very effective for the tremor if this is your main complaint. So this is criteria number 1, right? So that's supportive criteria that you have a dramatic response to levodopa, okay? Positive response. Number 2, the presence of levodopa-related dyskinesia. And we are not saying induced dyskinesia, although it's technically induced, but if I take levodopa, this is not going to happen to me because I don't have Parkinson's disease, right? So you need to have Parkinson's disease and you need to take levodopa for a certain amount of time in order to have dancing-like movement. This is what we call dyskinesia. Dyskinesia is basically saying abnormal movement. So it's a very vague term, but in the setting of Parkinson's disease, when somebody is telling you, oh, you have dyskinesia. So dyskinesia is like you are having this type of movement, which is dancing, or like Michael J. Fox type of movement when you see in the TV. Or you can have a normal posturing as well, okay? So if you have that, and this is related with levodopa, so you take your levodopa, and 45 minutes after, 1 hour after, you start doing that, okay? This is characteristic for Parkinson's disease, especially if the movement is in the trunk and the head, okay, and the arms too. The mouth is different. But still, you can see that with Parkinson's disease as well. Number 3, when you see a classic resting tremor, which is the typical low frequency tremor, approximately 4 hertz, like this, in the fingers. When the patient is walking, standing position, this is a classic for Parkinson. And when the patient put the hands up and the tremor goes away, and after a few seconds start again, this is re-emerging tremor. This is characteristic for Parkinson's disease. Most likely your diagnosis, I don't want to say 100% sure because there's nothing 100% sure in medicine, but this is Parkinson's disease. So you don't need to look for anything else in those cases. This is classic. So you observe those patients in the hallway, or you are waiting in the airport and you see people walking and you see a guy with a classic 4 hertz resting tremor, decreased arm swing. This is Parkinson's disease. Most likely tremor predominant, most likely, right? Because this tremor is characteristic, very characteristic. So that's number 3. Number 4, this is the one more difficult. Decreased sense of smell. So this happens when you test patient objectively, and there is a test that you pay for that. And you detect decreased sense of smell. This is characteristic for Parkinson's disease. It's not unique because you can have that in patients with Alzheimer's too. But it might help because you are not supposed to have that with patients with multiple system atrophy or PSP. So that might help, but it's not enough. And it's difficult to be sure. You ask patients and they might tell you, no, my smell, I think it's okay. But when you test them, it's not okay. The other thing is there is an abnormal nuclear medicine test that we call the MIBG. You will see the letters here, which is a nuclear medicine test that the medical insurance is not going to cover for that if you are looking help to make the diagnosis of Parkinson's disease, at least not in US, okay? It's very unlikely that the medical insurance will cover for that. It's possible, but it's difficult to get approval to get this test to evaluate your nerves, if your nerves are working well at the level of the heart, okay? It's abnormal in the setting of Parkinson's disease and tend to be normal in patients with MSA, multiple system atrophy. So if you have at least two of these four criteria, you have and no red flags, and obviously no absolute exclusionary criteria, the 9 that I discussed before, then you have the criteria for clinical established Parkinson's disease. That's your diagnosis. Okay? Now that we talk about red flags, so when you see these 10 red flags, that's an indication that you might be dealing with something else as well, and you need to get an MRI of the brain. And that's why it's so important to discuss these red flags. Let's go one by one. Number 1, rapid progression. So for example, if you start having significant deterioration, rapid progression of your walking, of your gait, significant problem with that, from the beginning to the point that you need to use a wheelchair within 5 years of symptoms onset, I mean the motor symptoms, the tremor, the slow movement, this is not Parkinson's disease. Most likely it's not Parkinson's disease, it's something else. So that's a big red flag. So if I see that, those patients automatically, they need to get a MRI of the brain because this is not typical, okay? Number 2, when you have the opposite, so you see these patients that they are doing really well, and you see, I'm seeing you for 3 years, 4 years, and you keep getting better. It's possible. I'm not saying that it's not possible, but only possible if you make drastic changes in your life. For example, if you were a person that you were diagnosed with Parkinson's disease, and the doctor told you you have Parkinson's disease, you need to make some changes, and you are one of those, I have a few, that start doing high intensity exercises. Like for example, Jimmy Choi. Watch the videos of Jimmy Choi. Okay, he keep getting better. So every time that I see a video of Jimmy Choi on YouTube, he gets stronger. And this guy is like a rock. You touch this guy, he's like a rock. So he got better after having the diagnosis of Parkinson's disease. So that's, if you see that, then you can explain that, right? But if you see somebody during 5 years, 4 years, they don't do exercises, they don't make any changes in terms of diet, and they stay the same, no progression, then you need to question about the diagnosis, okay? And that happened to me a few times, that I see patients during 3 years, 4 years, and then, he's not, there is no clear progression here. So those patients you need to reevaluate. And that's why the diagnosis of Parkinson's disease need to be reevaluated every year, because things might change. What looks like Parkinson's disease is not Parkinson's disease. It's something else. Okay, that's number 2. Number 3, severe voice issues. Okay, yes, we know that when you have Parkinson's disease, you have hypophonia, right? So it's soft voice. So when you see patient with Parkinson's disease all day long, you can identify the voice. It's like all of them talk the same way, all of them. Even if they have a different accent, right? Because everybody has a different accent. Uh, but it's different. And when you see a patient with PSP, they have a different voice too. And MSA, they have a different voice. It's difficult for me to explain you the type of voice. It's just you need to listen to them, and you will see that they sound different. So, but when you see a patient with severe voice issues that you cannot understand at all what they are saying, that's a red flag, especially during the first 5 years. You are not supposed, if you have Parkinson's disease, to have this uh, severe speech problem and swallowing problem. So if you are one of those that during the first 5 years, the speech therapist is telling you that you need to modify your diet in terms of now you have to eat soft diet because you cannot swallow well and you are aspirating, you need to look for something else, okay? Because yeah, it's normal that you can choke sometimes. That happened to me, and I don't have Parkinson's disease, but constantly to the point that you are aspirating, that's not Parkinson's disease, at least not during the first 5 years. You need to look for something else. That's a red flag. Big red flags, get the MRI of the brain. Number 4, if you are making significant inspiratory noises. So what is that? So I'm not talking about snoring, right? I'm not talking about snoring. I'm talking about noises like that type of noises. And sometimes they do like, so it could be when they're awake or when they are sleeping. So these type of noises you see in people with MSA, multiple system atrophy. I will post a video of multiple system atrophy later. But this is the kind of things that you need to pay attention because they are red flags against Parkinson's disease. Then let's talk about number 5, severe orthostatic hypotension. What is that? So has to be severe. So orthostatic hypotension means that your blood pressure drop when you stand up, when you are assuming upright posture, especially standing up. So when you stand up and your blood pressure drop 10 point over 10, that's a positive test or positive orthostatic vital signs. So if you have this issue during the first 5 years, that might be, you can see that with Parkinson's disease, but that might be a red flag indicating that you might be dealing with other type of problems such as MSA, or you can see that in dementia with Lewy body as well. So that's one thing. The other thing is that urinary retention. So retention and urinary incontinence are not features, are not characteristic for Parkinson's disease, unless you can explain that with something else, okay? So when you see a patient who is having retention, that's a red flag. You see that with patient with multiple system atrophy, okay? Number 6, frequent falls. People with Parkinson, they fall too, right? I don't have Parkinson, I have few falls. But when it's recurrent, that's not normal, especially during the first 3 years and you're falling down frequently. That's a big red flag against Parkinson. So those patients require a MRI of the brain, because when you have some patient with Parkinsonism, and they're falling down frequently, you start thinking about atypical syndromes such as multiple system atrophy, PSP, progressive supranuclear palsy, or cortical basal degeneration, all these things, or dementia with Lewy body. Number 7, excessive abnormal neck flexion. So we call that anterocolis. So, or contracture of the hands. So contracture. So the hands get like this. So that's not characteristic for Parkinson's disease. You see that with other conditions such as MSA. So I'm telling you, all these red flags are things that you identify and make you think that the patient is having other disease. Similar to Parkinson's disease, but it's not Parkinson's disease, like MSA, okay? Number 8. So number 8 is if you have for 5 years, motor symptoms, for example, tremors, stiffness, slow movement, and you don't develop non-motor symptoms, that's not Parkinson, that's a red flags, because typically people with Parkinson's disease, they will have motor symptoms. Motor means tremors, the stiffness and the slow movement, but also they have depression, the majority of them, not all of them, right? But at least 50% of them, they will have depression, anxiety, they have decreased sense of smell, they have bladder issues, they have sleeping issues. So if you have a patient with motor symptoms and never non-motor symptoms, that's a red flag, okay? That's number 8. Number 9, unexplained hyperreflexia. So you see a patient with hyperreflexia, that you check reflexes that are very high and especially asymmetric. So one side worse than the other. And they have what we call a Babinski sign. Babinski is when you put like tuning fork on the sole and you see upgoing toe, the big toe like this, and fanning. So that's not normal. And if you see that in patient that you are suspecting Parkinson's disease, that's a red flag. Unless you can explain that with a stroke, right? Because there are patients with Parkinson's disease, they can have a stroke too. So you have a stroke on the right hemisphere, you can have a Babinski sign, which is upgoing toe on the opposite side, and you can say, oh, the patient have that because patient have a stroke. So you can explain that. But when you cannot explain that, that's a red flag. And whenever you see hyperreflexia, you need to get an MRI. It doesn't matter the cause. You need to get an MRI to look for etiology, for the cause, right? Now, number 10, and the last one, is when you have a bilateral symmetry. So bilateral symmetry. So bilateral Parkinsonism. So both sides the same. So in Parkinson's disease, one side is always worse than the other. Always. Okay? Always. So that's why patients always remember when you ask them, is the symptoms worse on the right, on the left, where the symptoms started? And they will tell you, oh, it started on the left. And the left is the worst side. It's more rigid, more slow. Sometimes they can cross, the symptoms can cross, right? Sometimes some patients, they have a resting tremor more pronounced on the left, but the stiffness and the slow movement is more pronounced on the right. Why that happened? We don't know. But I have seen that frequently, okay? So that's the 10 red flags. 10 red flags. So again, let me summarize to finish. Whenever you see red flags, any of these 10 red flags, or the nine absolute exclusion criteria that we discussed, get an MRI of the brain. Totally indicated MRI of the brain, okay? Very important. You ask your doctor, listen, I think I should get an MRI of the brain. They will do it. They will order an MRI of the brain. Now, otherwise, there's no indication to get the MRI. And let me tell you a few things. Let's talk about the cost of the MRI, at least in the area where I live, which is East Tennessee. So this is not cheap. Get an MRI of the brain is expensive. I'm talking about the average. If you check the average of how much is a MRI of the brain. It's between $700 and $1,500, okay, in the area. So it might go a little bit higher actually. It depends on many factors. One tip that you can do looking for save money is to try to get an MRI in an outpatient imaging center, which is often less expensive than hospital-based, okay? Anything that you get inside of the hospital, for example, you go to get an MRI in the outpatient, it's outpatient, but it's hospital, they will bill you for hospital. It's a hospital bill. It's a hospital bill. So you better go to a clinic or outpatient imaging clinic, which tend to be cheaper because they are not going to bill you for the hospital bill. The same thing apply with when you get the Botox injection or Xeomin or MyoBlock, all this botulinum toxin. So you get this in the hospital or in the clinic affiliated to the hospital, and you get the injections in the hospital, you will get a bill just for the doctor injecting you in the facilities of the hospital. And that's why when you go to a clinic and you see that why the doctor is seeing me in the regular follow-ups in a clinic, and then for Botox, they inject me in a different place to bill you, okay? Obviously, the hospital don't want me to tell you that, but that's the truth. So there is this is a business. So when you see that the injection is in another place, is because they're billing the hospital. But basically, you get the bill from the hospital because you are receiving the bill in a hospital facility. If you like this video, don't forget to subscribe to my channel. See you